Why don't we get started? Again, I'm Tavio Akimascu. Thank you for joining us for our second Implementation Science for Innovation and Discovery session. Some of you are on Zoom there, and I will be monitoring the chat during the presentation. Some of you are here in the room. The benefit is that you get food and drinks and the ability to socialize a little bit more than online. So again, thanks for coming. This is the agenda. So sign in, refreshments. I'm going to do some opening remarks, and then we'll dive in with a presentation by Professor Dr. George Easton, who's online from Atlanta, Georgia. I thought I would start with this slide that I found online recently about implementation science. So sometimes there is a huge gap, as we discussed last time, between knowledge and action, between how we discover things and then how we apply them in the real world. Sometimes we walk that line looking backwards, which is probably not unheard of in the world of healthcare. And sometimes we walk assuming that our path is very solid, and in fact, the strength of the chain is really related to the strength of the weakest link, right? So I thought that was an interesting cartoon about implementation science. Just a recap from the previous meeting. I thought I would go back and kind of recap the major concepts we talked about. So by definition, implementation science is defined as the scientific study of methods to promote the systematic uptake of research findings and other evidence-based practices or interventions into the real-world practice, with the ultimate goal to improve the quality and the effectiveness of health services and care. So maybe emphasis for this session would be quality. Other terms used frequently in the literature: dissemination and implementation research, or implementation and dissemination. Sometimes it's kind of understood that dissemination is one component of implementation, knowledge translation, translational science, and so forth. As we discussed last time, implementation science draws from a lot of connected or contiguous disciplines, one of them being public health, health services research, psychology, organizational management and behavior, human factors engineering, for example, quality management, and a few others. Another recap from last month, these are the three main concepts, key concepts for implementation science: fidelity, sustainability, and adaptation. As we discussed last time, fidelity is the extent, which means really degree, quality, and consistency to which an intervention is implemented across different settings or populations, as intended or specified in the original project, so that it produces the expected outcomes, and also it enables our comparison across settings or in different environments, and also replication. The sustainability refers to the long-term maintenance of an intervention or evidence-based practices after the initial implementation period, so then the benefits are sustained over a long time, and also maximizing the return on investment. The third one is adaptation, which is modifications or adjustments made to an intervention or evidence-based practice to fit the needs of a target population or setting, with the ultimate goal to increase its acceptability, feasibility, and relevance. And we discussed how sometimes fidelity and adaptation can go in antagonistic fashion, and how adapting too frequently may compromise the fidelity of the intervention. And I also wanted to remind you one of the most important slides that I showed at last meeting, which is the subway schematic of studies, if you want, in medicine. So it starts with identification of the intervention or practice of interest. It goes to the first station there, where if there is no evidence of efficacy, you would start phase 1, phase 2 studies for medications or devices, or early proof of efficacy studies, and that's the design for implementation. If there is evidence of efficacy, you would want to see how does that happen in real world, so you do effectiveness studies. Phase 3, phase 4, again, later phases for equipment studies. If there is no proof of evidence of efficacy, then you would actually go ahead and do effectiveness research, point of care research, real world efficacy if you want. If there is proof, then you would start going on this line, which is, implementation studies. And you can start with mixed methods, looking at quality and qualitative assessment, design the implementation-specific bundles of interventions, the so-called implementation strategies, and then you want to test the implementation strategies. And sometimes we find in the real world that we may have proof of effectiveness, but maybe it applies to only a subgroup of individuals or in specific settings, or the evidence is incomplete. And that may be the situation where you would want to start doing implementation research by using a hybrid effectiveness implementation design. And we spoke a little bit during the last presentation about this. So this is kind of the traditional subway schematic of implementation studies. So today's talk, it's about the intersection between quality improvement and implementation science. And we have a guest speaker, as I said, from Emory University, Goizueta Business School, Professor George Easton. He's an associate professor of information systems and operations management at Emory University, Goizueta Business School. Before joining Emory, he was a professor, a faculty of management at Rutgers University, and then associate professor of statistics and quality management in the Graduate School of Business, University of Chicago. He started out by getting a bachelor's degree in mathematics and zoology from Duke University. That's probably the closest he got to studying biology, but don't underappreciate that. That's probably, he has more experience with healthcare management than a lot of us. Then he followed that with a master's in operations research and systems analysis at the University of North Carolina, not too far. And then he went for a master's in statistics at Princeton University. And if that was not enough, he also got a doctorate, a PhD in statistics from Princeton University. His research interests include quality management, Lean Six Sigma, and statistical methodology. He served as an editor for the Quality Management Journal, published by the American Society of Quality Control at that time, now American Society of Quality. Professor Easton has worked extensively with industry in both quality management and statistics, and he served as an examiner and senior examiner for the Malcolm Baldrige National Quality Award. I have met Dr. Easton at Emory University during an executive MBA, where I took two of his classes. One was process analysis and Six Sigma, and the other one was Lean Six Sigma in healthcare, which was in fact an elective directed study course. I learned a lot from him about statistics, about graphic representation of data, Lean Six Sigma principles and quality management in general, as well as some concepts related to implementation science. So it is an honor to have Dr. Easton with us today, and without further ado, I will introduce Dr. Easton.
Thank you very much. I am thrilled to be here. I think this is a very important topic, and I think people are very likely to be a fantastic audience, and I'm hoping for some very challenging questions. I'm going to go ahead and share my screen because I'm going to be doing my own slide deck here. And so what I'm really talking about today is implementation science sort of through the quality lens. And in many ways, what I'm going to be talking about is kind of what we know from quality management about implementing in general, but implementing innovation. So I'm going to go ahead and begin here. If there are questions of clarification, please feel free to ask them. I will tell you I'm not highly skilled at looking at the chats while I'm talking about these things, so I don't mind if somebody goes off mic and interrupts me. Okay, so I wanted to begin by acknowledging some of the realities in healthcare, and so this slide, except perhaps for the very last, but are things that I imagine you all are painfully aware of. Healthcare is a service. And what that really means is that in services, you cannot separate the product from the process. In many cases, the process is the product. In addition, in many service processes, and this is certainly true of healthcare, the customer of the process is part of the production process. So the production process is typically working on the customer as kind of an input to the process. And that means that the inputs are highly variable, okay? Now, so far, you know, healthcare is not particularly unique in either of these characteristics. Healthcare is extremely complex, and it's getting more so, for multiple reasons. Part of it is the complexity of the treatments and the technology that's being used, but another huge part of this is that patients are presenting with multiple illnesses, and in fact, the more success that healthcare has, the more you all end up treating people that do have multiple serious chronic illnesses. Now, in healthcare, the incentives of the actors in the systems are misaligned, and third-party payment is part of that problem. And I don't want to go into any of this in depth. A lot of these things could become a talk in their own right. In addition, traditionally, payment has been based on the number of procedures that have been done, which creates a certain misalignment of incentives. Healthcare is a highly regulated business, so that's a key thing to worry about. There is always the threat of malpractice and other lawsuits, and I think probably more so in healthcare than in a lot of other businesses. There are strong and entrenched cultures within healthcare. The MDs have a culture, the nurses have a culture, the healthcare administrators seem to have yet another culture. In addition, and this may be something that a lot of people haven't thought about, the customers cannot evaluate the product in many cases. A lot of times they can evaluate their outcome, but it's very difficult, for example, for a patient to know if a surgery was performed well. Okay, and this is actually quite common in many businesses. So it's definitely a feature of healthcare, but it's not unusual in other businesses as well. Overall, the goals in healthcare are rather muddled, and part of the reason of that is that in a regular business, the profit motive provides a certain amount of clarity. And so what you have in going on in healthcare is you certainly have some profit motive. You have it at the level of the individual actors, you have it at the level of the organization, but at the same time, they're nonprofits and they have other goals as well. And they have people that are motivated in those systems by other issues as well. And right now in healthcare, there is a high reliance on temporary employees, and that's the traveling nurses I'm primarily thinking about, but that adds a complication as well. Now, a positive in healthcare in comparison to other businesses is that there is no restriction on interactions with your competitors or peers or other healthcare organizations. Okay, there's no competitive or antitrust issues. And so this actually makes healthcare quite different, because in most businesses, if you're trying to implement some kind of issue, you can't just go look at how your competitor has done it. Okay, so there is an openness in healthcare that is absent in some other businesses, but it actually also creates certain problems that we can talk about a little bit later. Now, I have two slides here that I'm essentially going to skip because Tavi talked about these. These are statements that I've pulled out of definitions of what implementation science is. And basically, I'll just flip through these extremely quickly because they are repeating the things that we already know, that you already know from your prior and the prior talks. And I want to get into this slide, which I think is potentially important. The implementation of any innovation in essentially any organization begins with some kind of opportunity identification process. And I'm going to be expanding on this a bit, but there needs to be some kind of, I'm going to use the word surveillance, which means how you are obtaining the information about potential innovations that you might consider implementing. And in addition to identifying these opportunities, there needs to be some kind of selection criteria for actually deciding that you're going to try and implement these in your organization. So there's a lot of issues here. This opportunity identification can be occurring in an organization in anywhere from a completely informal manner, where people just hear about something and then they think it's an opportunity, to extremely formalized process where you are routinely looking at various journals or various other businesses or organizations in order to try to identify opportunities that you might want to implement. There are basically three phases to the implementation of an innovation. And the second one occurs when you have decided on something that you basically want to try. And I've labeled this box opportunity deployment, but there is an issue here around potentially designing how you're going to do the deployment. There are a variety of different ways that you might go about it. In many cases, an opportunity will be implemented in the organization, some kind of pilot effort, so a small scale. And then ultimately, if that proves to be promising, it will be rolled out into regular operations. And there are many, many other issues here around designing a deployment. For example, there's the issue of resistance to change in organizations, and that's something we can talk about in the question session if you are interested in that. I will say that I nearly wrote a slide for this for today, but I didn't do it. But it builds on some of the things that were said a little bit earlier. Things that work in the lab are not at all guaranteed to work in practice, okay? And I will come back to this, but even things that you can get working in practice when you have a team driving it, when it's sort of the initial implementation of this idea in regular practice, even those things frequently won't work when it gets into, I'll call it regular practice, where there's not all that effort of these skilled implementers trying to make this thing work. Okay, and in addition, in terms of deployment, in many cases, an innovation will first be piloted in a particular area or department, and then you'll get it working in the regular operations of that particular area or department. But if you try to roll it out laterally across the organization, it fails. Okay, because it really only works in that department the way it's designed. So there's a lot of fall off in this process of ideas because you can't make them work essentially. But then finally, when you have something that really works, it needs to be put into your ongoing operations and rolled out laterally to the appropriate areas in the organization. And then it needs to be assessed on a regular basis. Is it functioning the way it's supposed to? And then ideally, it will be systematically improved. So when I'm thinking about this whole issue in a real organization, I'm really thinking about surveillance, about intervention design, that's the middle box, and then about making it work, standardizing it in regular operations. Okay, so now going back to implementation science, the kinds of adjectives that are used in the definitions are: this approach needs to be systematic, it needs to be evidence-based, okay, it needs to be integrated into routine practice, the context matters, and it needs to be scientific. Okay, and there's a large discussion we can have about many of these words. Some of it will come up a little bit later in the talk. I will make the comment in my look at the implementation science literature, to the extent that I've looked at it, the main emphasis seems to be on bringing outside innovation into the organization. Okay, and I've posed a question here and then sort of answered it, but well, the question is, and this is particularly important as it relates to sort of the quality view of all of this, is internal process improvement a part of implementation science? I think it probably is, although it's pretty clear that the primary emphasis in this area is on bringing external innovations into the ongoing processes, into the organization. Okay, so I'm going to talk now a little bit about what quality means, and this first slide, in some sense, refers to kind of traditional quality. It's the small q quality. It's focused very directly on the process level. It usually focuses very little on human factors, on the operational organizational issues. Instead, it focuses on work methods and technical issues. It would include things like measurement calibration, statistical process control, various kinds of sampling for the purpose of measuring the process. Lab testing might be a part of this. And there are a lot of these things which are generally technically focused primarily, that have to do with controlling the quality of a process at sort of the frontline process level. The quality lens from the big Q, however, and this is important, it focuses on management systems for driving operational excellence. Okay, and examples of this include Lean Six Sigma, Lean, Six Sigma. Some people distinguish between the two. I tend to look at Six Sigma as being Lean Six Sigma. Prior to Six Sigma being and Lean being a real thing in the US, there was another approach called Total Quality Management. It was built on another system called the Toyota Production System, and then another framework that you might use to think about these quality systems might be based on the Baldrige Excellence Framework, which is really an assessment approach for organizations. The quality big Q, the systems, includes all of small quality. Okay, and so a very central idea in both small quality and big quality is the concept of a process. Okay, and I'm going to return to that in just a minute. It turns out that a lot of these things, like the idea of a process, sound very simple, but when you actually look at where the rubber meets the road, they can become rather complex. I want to back up a bit here and say, you know, I began studying this in organizations around 1990, so I've been at this more than 30 years. And what I was studying at the time was the implementation of total quality management systems. And when I say a system here, I think I'll say this in the next couple of bullets. These systems focus on organizational structures, which means things like teams and steering committees, on planning and deployment, on customer focus, and for the purpose of this talk, when I use the word customer, you can think patient, although there can be some ambiguity there. On supplier relationships, on systematic improvement and problem solving. Big quality in these quality systems also focus on many human and behavior related issues. Okay, and so there is a very major piece of big Q has to do with human beings. It focuses on cycle time. It doesn't just focus on the production processes. It focuses on product and process development, on strategic issues around that and other things such as time to market and so on. So if I talk to you about, or if I'm using the words Lean Six Sigma, I'm talking about a large and pervasive system within the organization for driving this progress, hopefully, towards operational excellence. Also, in essentially every quality management system, a problem-solving process is central. And these problem-solving processes go by a variety of different names. The one that happens to be primarily a part of Six Sigma is called DMAIC. Before that, a commonly used structure was called Plan, Do, Check, Act, and so on. The Japanese have a system or an approach that they call the QC story, and so on. The key point is that systematic and team-based problem solving is central to these quality management systems. And this team-based problem solving is based on the scientific method. And so the idea that this improvement system is evidence-based is actually a central tenet of these quality management systems, going back to the systems developed in Japan after World War II, where the terms that were attached to the evidence-based idea was management by fact. Decisions needed to be based on data. These quality systems, what I'm calling big Q for the purpose of this talk, also include looking outwards. They include things like benchmarking, and in addition, measurement is key. And I want to come back to benchmarking. I will do that later because I think this is an important parallel in the quality systems to this idea of implementation science. In any case, another feature of these quality systems is a lot of metrics, a lot of reliance on metrics. Okay, so this whole issue of measuring the management system and the process is important. And so key adjectives that I would attach to these systems is that it is a system, it's organization-wide, and it's broad in scope. Okay. So in this slide, what I want to do is kind of compare implementation science with structure which tend to be in other businesses. So in healthcare, we have research, okay, and the flavor of implementation science is that innovations that are coming from this research that this research is the source of the innovations that are going to be deployed through the sort of the implementation science process. And so the kind of innovations that we're thinking about are potentially new drugs, potentially new care procedures or methods in surgery, potentially new equipment. So there's a lot. Okay, and of course, many or most of you are involved in healthcare research, so I don't really have to tell you too much about that. But that is, in the implementation science view of the world, is distinct from implementation science. And I've pulled the three boxes from my previous slide and put them here. That's the opportunity identification or surveillance, the development of the strategy for deploying the innovation, and then the integration of that in ongoing improvement. Well, so what do we have in other businesses? Well, we have R&D. Okay, now R&D is research and development. It has some parallels to research in healthcare, but it is not the same. In part because it involves less basic science, and in addition because it is typically very focused on getting to a product. But we have other structures as well. We have structures around surveillance and intelligence. So there may be a system in place for technology surveillance, for understanding what potential technologies can affect the business. There oftentimes will be competitive intelligence, which is a thornier problem in other businesses because unlike healthcare, you just can't go in and look at your competitors. you can typically look at their products, or if they're service business, you can use their services. There is a whole area that I've put under this surveillance and intelligence that really is connected to marketing, and that is market and customer intelligence. And then this IDIV benchmarking, which I'll come back to, is really part of the quality management systems. So there's this whole surveillance box in other businesses. There are then specific boxes around designing products. Okay, and so the people involved in product design might, in a manufacturing company, might involve a lot of engineers, might involve a lot of marketing people, and so on. There is in many cases explicit process design. Okay, there is the information technology function in that organization, and I'm going to make some comments here in just a second that will sort of explain why I have these boxes here and in this order. And then there is operations management, the actual, running of the operations of the company, which would very much include the quality systems. Now, how do these boxes in other businesses relate to implementation science? Well, opportunity identification would be coming strongly from the R&D function, as well as these surveillance functions. Some of it might also come from product design, but let me, all of this, of course, is an oversimplification of reality. The opportunity deployment, how you would actually design how to drive this into the organization, would be typically coming quite strongly from process design, but it also might be coming from product design in the information systems area, the IT area. And I'll cycle back to that in just a second. And then the sort of the knowledge set around the ongoing operations and improvement is going to be coming out of the operations management area. And I think this is an interesting comparison to make, because some of these boxes aren't obvious in healthcare. Let's put it that way. And in fact, they're typically not obvious in service businesses. So I've got some comments to make here. I've already made this one. Healthcare research and R&D are in some sense similar, but they are not the same. I'm not creating an equivalence there. The surveillance intelligence functions are often missing or incomplete, even in non-healthcare businesses. And this especially is the case in service companies. So that parallel between healthcare as a service and other service companies may to some extent explain some of the components that are kind of typically missing in healthcare. Clearly developed product and process design functions are often incomplete or missing in service companies. If you go into pretty much any manufacturing company and ask to talk to the people designing the product, they will take you to an identified organizational structure, and you'll talk to people who do that. But that is definitely not the case in a lot of service businesses. If you go in and ask them who's defining their products or their processes, because those are kind of one and the same, it oftentimes, obviously those things got designed, but oftentimes it's a one-off, okay? Or, as this bullet will say, in service companies, in many cases, the predominant thing that is structuring the product is actually the information technology systems. And so in a lot of service businesses, product and process design is actually happening inside the IT function or in conjunction with it, and yet it's not explicitly recognized as what those organizations are doing in the same way that it would be recognized in a manufacturing company. All right, so part of what might be insight from both the quality management systems and looking at how other businesses are structured has to do with organizational components around really around innovation and product and process design and surveillance that are in many cases missing in service companies, and I think in many cases missing in healthcare organizations. And I'll add here that around each of these boxes that I have under the other businesses, there is extensive literature in different fields. Okay, so there is extensive literature on many of these boxes in the literature of academic business, but also in engineering fields and so on. So there is a lot that is known to some extent, and I'm kind of hesitating there because I think less is known than we tend to think, quite frankly. But there's a lot of research that's been done around a lot of these things. And of course, healthcare can certainly borrow from that research and what is known. All right. So I want to make a point here, which is a critical point. It's kind of a basic point in some ways, but it's absolutely critical. And I'm going to talk a little bit about what a skilled craftsman model of work is. A skilled craftsman model of work means that one person or a small group of people are responsible for production, and they really control it. They perform the work their own way. They typically choose, to a large extent, maybe not completely, their own work methods. They choose the order of the tasks that they do. And they basically are controlling how the work is done. And I'm using the term skilled craftsman here because the image that I want in your mind is a skilled craftsman doing something like hand making a pair of shoes or something like that. Okay, these skilled craftsmen have knowledge, skill, legitimate knowledge and skill, and/or experience that makes them experts in this work. And this expertise is believed to justify performing the work in their own way. In other words, because they are skilled experts, artisans, whatever word you want to put on it, that expertise is the excuse, I guess, for allowing them to do the work their own way. They are generally, in addition to doing the work their own way, they're generally responsible for assessing the quality of their work process, their work product rather. And in many cases, because they're working in an informal system, assessment generally involves visual inspection, okay? Now, a particular skilled craftsman or the equivalent of what I'm calling a skilled craftsman, which is this small work group, which is designing their own work. They may or they may not have developed systematic approaches for performing the work. But the key point here is that even if you have a group who have, or a person who has a very systematic way of doing this work, the way that work is done will be done differently by other craftsmen in the organization or these small groups. In other words, each of what I'm calling the skilled craftsmen will be typically doing the work in a different way. In many cases, you become a skilled craftsman via apprenticeship. Okay, now I suspect that many of you are looking at my list of skilled craftsmen here and comparing it with what happens in healthcare and actually other businesses as well, or other organizations, and realizing that this happens a lot. So in particular, traditionally, MDs and certainly professors in business schools anyway, lawyers, and many other white college or knowledge work professions have functioned using this skilled craftsman model of work. But the problem is that of work design approaches, a skilled craftsman model of work generally produces low quality. And without the structure and I'll be talking about this in just a minute. And by the structure, I mean the structure of a system and measurement. Production will vary greatly because, for one thing, it's going to be varying between, the skilled craftsmen because they're doing it their own way. It will be unstable, which means that it may perform very well for a period of time, but then it may fall apart. But if the work is done in a skilled craftsman fashion, then I am confident in telling you that the quality will be low, the variation will be high, and the product will be unstable. Okay, I mean, this is one of the learnings, the key learnings from the quality area. In addition, there will be many defects and much rework. A lot of rework happens before a defect occurs, but some of those defects will escape to the customer. Now, having said all of this, sometimes a skilled craftsman model of work is unavoidable, but this should never make you feel happy. Okay, and there can be a dozen reasons why a skilled craftsman model of work may be appropriate or unavoidable. Part of it is it may be a very low volume task, which is only done, a couple of times a year. There are reasons, but when work is done in a skilled craftsman model, the quality is low in the quality management sense. So I want to now talk a little bit about processes, because processes are absolutely central to the big quality view of the organization. And what processes are really about, and the way I would like you to think about the notion of process, at least for this talk, is processes are about structuring the work. So process concepts have to focus on work methods. That is, they have to address how the work is done, as well as just what the requirements are. So there's a difference there. There's a difference between method and what the requirements are in terms of some particular metric or so on. The details of any process obviously depend on the work to be done, on where it's being implemented. But some generalizations can be made about process architecture at a high level. When you have repetitive transactional service processes and they correspond to manufacturing, the way the process can be designed is often like an algorithm, like a flow chart, and the process can be defined in great detail. But processes for higher level knowledge work generally involve frameworks, and each stage of these frameworks are supported by menus of various things. In many cases, the menus are menus of data or measurements that you should consider collecting. It might be menus of analysis tools that you are potentially going to use to analyze this data. It might include menus of issues to consider or taxonomies or so on. But the more the work is like knowledge work and abstract, the more the process will look like a framework supported by menus. And I may say this on the next slide, but I'll say it here in case I don't. The design of the process has to work well for the work. Okay, it is a very big mistake to try to take knowledge work and force it into a linear flow chart the way quite a bit of sort of frontline work can be. In defining processes, training is key. And other words for process notions include method, methodology, approach, procedure, protocol, strategy, consistency, and there are other words. And I often avoid using the word process in real world context because it potentially alienates people. But I certainly can go into a workspace and ask, does everybody do this the same way? And incidentally, if the answer I get is either no or I don't know, it means that they don't do the work the same way and there is not a process. Okay, so process is about whether or not the same approach to the work is taken by everybody doing the work. Now, why is all of this important? Well, the answer here that counters the low quality of skilled craftsman model of work is the development of processes and systems, and then measuring them and systematically controlling and improving them. I'm using some words that have technical meanings in the context of quality management. I'm going to rely on sort of either your knowledge of that stuff specifically or it's sort of their common meanings. Processes must evolve over time. Okay, they cannot remain static. I'm sure there's one or two exceptions, but this really requires an improvement process. And one of the major pushbacks against process notions is bureaucracy. And what bureaucracy is, too much structure focused on the wrong things and usually obsolete. So when you look at bureaucratic processes, they oftentimes focus on internal controls and not on the customer. So there is an issue here. The skilled craftsman model works badly. Okay, processes risk bureaucracy. Okay, and so that needs to be, in some sense, reconciled. And it's reconciled by continuously improving. So by the way, you avoid bureaucracy by relentless customer focus, cycle time reduction, because speed tears down bureaucracy. You cannot do things quickly in a bureaucratic system. And also process improvement methods or approaches such as process simplification. Okay, I noticed that Andrew Downard is on this call, and I'm going to be referencing him in just a second here. I'm getting close to the end of my time here, so when do I need to actually stop? I've lost track of the schedule. No, he's going to answer me. Okay.
We have about a half hour left.
And we want at least 15 minutes for discussion, right?
I believe you're correct. Yeah.
Okay. All right. Very good.
Thank you.
So later in this series, Andrew Downard is going to talk about this idea of maturity models, but I want to just briefly introduce it here. The earliest quality maturity model that I know of is from a book called Quality is Free by Philip Crosby, and it was published in 1979. And Crosby's maturity model became the basis for what became known as the software capability maturity models. Okay, and I've given you some references for these things. And then later in this series of talk, you're going to hear from Andrew Downard about these maturity models. I didn't know Andrew was going to be on this call, but Andrew has great, fantastic material around this and terrific insight. I am just going to very briefly introduce this because I need the idea of organizational maturity to make a point about implementation science. This is the maturity model out of the 1979 book. And basically, you have issues or structures down the left-hand side. I'm going to zoom in on this in just a second. And then you have 4 or 5 stages. So if I go to zoom in here, yeah, there we go. So let's just basically look here at the issue of quality improvement actions and his summary here of this stage. So this is the most primitive stage here. So what he's saying is that the quality improvement actions in the beginning, there's no organized activity, no understanding of these activities. And his summary is, we don't know why we have problems with quality. And then as you begin to get more advanced in this, step 2 here is trying obvious motivational short-range efforts. Okay, and then as I'm going to focus here on this particular issue, quality improvement actions. And then we get into stage 3 here, and he talks about implementing his 14-step program. But the idea here is that there's now a systematic approach to dealing with these issues in the organization. And then levels 4 and 5 have to do with the degree of deployment, because it takes actually several years to get these systems typically to work, but finally ending up in a phase where quality improvement is a normal and continued activity. So this goes back, or it has sort of historical interest. It goes all the way back to 1979. And then this was picked up by a man called Watts Humphreys, and it was modified into applying to software. And really, these maturity models took off in the context of software. Okay, and so Humphreys' phases are initial. The software process is characterized by ad hoc, and it's occasionally even chaotic. He uses the term repeatable, which I think actually is much too generous for phase 2 of this. But you're beginning to see basic, remember they're thinking about software here, but basic project management processes are beginning to be established. So this would be rudimentary notions of process. And then 3, you're beginning to see that processes have become pretty well designed. And then he goes on to 4. You're really beginning to get management and control of these processes. What he says here is they're quantitatively understood and controlled, and then you have an aggressive improvement process. Okay, and again, don't miss Andrew's talk on maturity models. He takes this and morphs it into organizational things in a way which I really think is fantastic. Okay, so here are the observations. Most organizations are in stage 1 or 2 of these maturity models with pockets of stage 3. That's a typical organization, particularly in the beginning. But they think they're in stages 3 or 4 with pockets of stage 5. Okay? And the point here is that deploying any innovation or an external innovation in particular into a stage 1 or 2 organization is very, very different from deploying it into a stage 4 or 5 organization. So if you think deploying into stage 1 or 2, think about cat herding. Okay, you are deploying into a chaotic system or a system with just the beginning of structures. So, what are you going to be doing? You're going to be persuading. You're going to be communicating. You're going to be begging, pleading, justifying. You're going to be trying to get all of these skilled craftsmen who are doing their own thing to try to get on the same page to implement this innovation. And I think, I hope I've built this story in a way that it's pretty obvious that that is a very difficult thing to do in an organization which is functioning or largely or to a great extent in an ad hoc fashion. So what's the difference in stage, there's a typo here, it should have been stage 4 or 5. Well, in stages 4 and 5, you have the machinery of the quality management system to test and deploy the innovation. Okay. The problem-solving process can be used to stabilize innovation and resolve any bugs. And in a truly disciplined, process-oriented organization, if you change the process, you implement the change, because the culture of the organization is that you follow the process. Now, this is an oversimplification of a very complex set of issues, but it should be clear to everybody that trying to implement something into an immature organization in terms of processes and quality management is a very, very different thing to do than implementing it into an organization where not only are the structures in place to define and control the work, but also there is a vibrant system in place to actually do the improvement. So from the quality systems lens, if you want something to be done, and you want it to be done routinely and consistently, you need a process. And in addition to just the process, you need the structures associated with effective processes. So documentation, training, measurement, control plan teams, steering committees, and so on. So what this means in terms of how I've sketched out this implementation science with the 3 boxes, you need a well-developed methodology for innovation surveillance and for innovation deployment. And so the focus of this slide is on the innovation, how you identify what you want to do and how you bring it into the organization, at least in the beginning of that process. But in order to systematically deploy the innovations, work out the inevitable bugs, and then deploy widely in the organization, you need a well-developed quality management system, because that's what that system does. And so the focus of this bullet is no longer on the innovation you're trying to deploy, it is on the thing you're trying to deploy the innovation into. And so for really effective implementation, you need to be stage 3 or greater. Otherwise, you're trying to deploy into chaos. And so this is a quote from, and I'm probably not going to have time to really get into this. This talk is written in a way where I knew I wouldn't get to everything. And pretty much if I stop at any point, I've given you, hopefully a useful product. But this is a quote from the first of the 2 papers that define and I'm forgetting the acronym. But the first of these 2 papers, I'll get back to in just a second. It says, many interventions found to be effective in health services research studies fail to translate into meaningful patient care outcomes across multiple contexts. And my reaction to that is obviously, okay? For the reasons which I've been just developing, because in many cases, well, firstly, there's a fall off. Things work in the lab that don't work in practice. Things work in practice when they're getting a lot of attention that don't work in regular practice, and things work in practice in one area that sometimes don't work in practice in other areas. But then in addition, if you're trying to deploy into an organization which is immature, good luck. And you can do some things. I don't want to be too sort of negative about this because you can have impact on organizations that are chaotic. So what is the fall off of things that work in the lab but not in the real world? Well, I'm not sure how much, but I figure it's probably 25 to 50%. All right, so I'm going to skip this and wrap up here. I'm going to skip these slides. Well, actually, I'll talk about this slide. So how do you develop a process? So, what I'm thinking here is a healthcare organization needs to have a well-structured process for identifying innovations and then bringing them into the organization. Well, the very first thing that I recommend doing if you're trying to define a process is ask the question, is the work currently being done? If so, how? So if innovations in an organization, external innovations are being identified and then brought into that organization, even if it's in an unstructured and ad hoc way, I'm going to start by trying to figure out how the work is currently being done. Now, if the work is being done, I can think about building a process based on essentially generating consensus around that. So can consensus be generated based on how the work is currently being done and a process developed from that consensus? But there is an idea of benchmarking that is very important, because benchmarking is an innovation process that is well identified, and you can search for benchmarking. You'll find books and methodologies that are developed. But benchmarking basically says, okay, we want to do this thing, say, of moving external innovations into the organization. And it asks the questions, what organizations do this well? How do they do it? Do organizations outside of healthcare do something similar? This is an important idea because you often get more innovation by looking outside of your industry than within it. And in regular businesses, in many cases, you can't look inside your industry. You're prevented from doing that because of competition and antitrust. That's not true in healthcare, but in quite a few cases, the real innovation occurs when you go and look at how a particular issue is addressed outside of your industry. And so if you find examples of this task or issue being addressed by other organizations, then you can basically try to copy their process. Okay, or maybe you see 2 or 3 examples and you get your team together and you try to figure out how to merge and take the best parts of those processes. Okay, so benchmarking is a key idea for driving innovation about processes into organizations, and certainly could be used to develop a systematic process for doing the surveillance necessary for identifying opportunities, having criteria for which ones you should try to implement, and then implementing them. Okay, I'm going to wrap up here in just a couple of minutes. There is this consolidated framework for implementation research. I know that Tavi had referred to that in his introduction slides that he started the session with. The original paper was published in 2009. It was updated in 2022, and it seems to have gotten the status of being the predominant framework in this area, and this is just based on a quick sort of look at the literature from my perspective. So it's possible that I don't have that quite right. It does have its own website, okay, which is actually quite useful if you want to know about it. This original framework was developed through literature review of 19 previous models for implementing innovation that were published primarily in healthcare. A couple came out of the psychology literature and a few came out of the business literature. This framework has 5 main domains. They are intervention, outer setting, inner setting, individual's domain, and characteristics. And I'm going to very quickly get to my main point here. Each of these domains consists of multiple constructs. So I'm going to try to click on this, see if I can bring it up very quickly. Of course, it came up on the other page. Let's see. Just pull it over here. Have I pulled it over? I hope this is the right thing. Yes. Okay. So, for example, under the first one, we have all of these sub-constructs, okay? And some of the sub-constructs have more sub-constructs and so on, okay? And now I'm going to go ahead back to my talk. This is a fabulous checklist for a large number of great ideas to think about. But it's not an implementation process. And I'm not sure that it really claims to be, but it seems to be frequently referred to in that context. It is much too long to be practical. What it really amounts to is a laundry list. There are 40 constructs within the 5 basic categories, with some having sub-constructs. And truthfully, I think it's too long and complex even for research. In addition, and I'll stop the talk with the Pareto principle with 15 minutes left, I guess, for questions. In addition, the Pareto principle suggests that only a few, and if we look at 20% of the 40, that means about 8 will be very important. Now, it could definitely be a very useful framework to inform development of a useful but much simpler tool for evaluating potential innovations for implementation. So I'm going to end with the Pareto principle because it's so widely pervasive. It is the 80-20 rule. Everybody knew that. Traditionally in the quality disciplines, what people say is that 80% of the effects come from 20% of the causes. But the Pareto principle is really a much, much more useful notion, because what it means is that usually, almost always, in almost every context, a small number of factors account for the vast majority of the effect. And so I tell my students that the Pareto principle is a gift from God. Okay, and now I'm going to tell you why. It is pervasive. The world really does work this way. Because of this fact, it allows for vast simplification, because you only really need to focus on what's important. And because there are only a few important things, it demands setting a small number of priorities. And in addition, it enables development of processes even when the inputs are highly variable. And the reason is, if you look at any work process, almost, then the vast majority of the cases that you have to look at fall into a small number of categories, and you can develop processes for those small number of categories because you basically have the volume of cases to do that. Okay, so I'm going to go ahead and stop the talk there and solicit any questions. I'm very, very happy to take any questions that you want to ask, including if they are from a skeptical point of view.
I have a question. Can you hear me?
Yeah.
So you talked a lot about the skilled worker training, workmanship, but also a lot of this comes from their training, right? So like when we're hiring somebody, we're not trying to hire everybody who lays bricks exactly the same way, right? We're usually trying to hire one programmer who has a certain skill and another programmer who has a different skill. Never hiring two people to do exactly the same thing. And this goes for virtually everything from clinicians to statisticians, whatever. So I'm just kind of curious if, I don't know, maybe it's not a good question.
So no, it's a great question, actually, and not one that's been put to me in exactly that context before. So when you are assembling a team, in many cases you are looking for people that have complementary disciplines, right? But it's quite likely, particularly in larger organizations, that you're going to have multiple teams that are doing similar things. If that's the case, you don't want those teams typically approaching the work in entirely different ways. Okay, and you certainly don't want this around the primary product that you're producing for your customers. In other words, in this case, the healthcare services, because if everybody's doing everything in a different way, then you and in particular, if they control their work methods and measurement is not particularly good, then you know that there's going to be a lot of difference between how different people do the work. And almost certainly, as a result of that, there's going to be a difference in outcome. Okay, so I guess I would answer it that way. I think you're absolutely right. You're not necessarily looking for duplicate skills when you are creating a team, but from a sort of a management system perspective, you're looking at whether you have multiple teams that are doing the same kind of work. Okay, now, when I said the skill craftsman model is unavoidable, if you are tackling a problem that's actually in the tail of the Pareto principle, where you see very, very few of them, it may make a great deal of sense not to try to develop a process for that. Okay, so you may live with the skilled craftsman model, but even within a team, you're much better off if there's an agreement as to how, for example, the team is going to function. So, maybe you have a meta-level process that the problem-solving process creates in the quality management systems, where we basically say teams are going to function in this way. I don't know. I'm interested in your reaction.
Yeah, no, I mean, I hadn't thought of it from the team perspective. I was thinking of the individual, but Yeah, I guess I don't know. I guess when you're talking about processes, these are typically things that one person can't accomplish all by themselves, right?
Well, that depends. If I take an example of automobiles, normally they're built on an assembly line. But 20 years ago, I think it was Saab. It might have been Volvo. One of those companies experimented with having the car be built in place by a team dedicated to that vehicle. So you can organize your production.
Wait, did that work?
Well, it did not work. The quality was incredibly high, as it turned out, but the production was incredibly slow. Okay, and in that particular case, the frontline people had tremendous pride in what they were doing, which is why the quality was high. But that probably also was a startup effect as well. Okay. But the key thing is, even when you have to live with the skilled craftsman model, it's producing bad quality in the way quality is defined in these systems. Okay, it's creating high variation and disruptions, which are called special causes. And that's true of me. I mean, I work as a skilled craftsman because my organization is set up that way, and I know that working as a skilled craftsman is not a great model of work.
So if you use a skills craftsman model, but you apply industry standards of assessments and measurements and processes, is that still a flawed model, or is that acceptable model?
Well, I think
it's self-imposed, self-adopted
yeah.
processes and stuff. But
I think I'll answer it this way. If you have a skilled craftsman model, but you have really good measurements, what you're now going to be able to do is see the variation created by the different people. Okay, and you're also going to see the fact that that there are disruptions over time. So I think that's what happens. If you have multiple people doing the same work, and obviously in healthcare you do, because you have multiple patients. So the work in some sense is done over and over again. Without the structure of a process, at least at some level, you're going to have variation and disruption. Okay, I mean that is just something that we know from the quality discipline. Probably close to as well as we know that that the Earth rotates around the sun.
Related to the skilled craftsman paradigm, I remember years ago I got a call from an administrator asking, "What's your standard operating procedure for abnormal bronchoscopy results?" And I paused, and then I said, "Medical school." Because there's no way you can standardize what you're going to do with every single result from bronchoscopy. But then right away, I'm becoming self-critical. I said, can we standardize any of those processes? Is there any way we can create an algorithmic approach? And the answer is absolutely yes. I was going to ask you a question on a little bit of a different topic, which is, how do total quality management principles apply in this type of setting, on implementation science, scaling up innovation, either outside innovation or internal innovation? Is there any way we can adapt the total quality management experience?
So I would say absolutely yes, and in multiple. I mean, there are that's the answer to that question is complex, but the first thing is, if you want to, in an organization, a healthcare organization, routinely identify and bring into practice innovation, you have to have a well-defined process to do that. The identification and the design of the intervention, and you need on the other end of that a well-developed system for stabilizing and implementing. Okay, and so you know, that's the first, that's the most central point here. Okay, now there are many other layers to this quality management system. Typically, all of these things would be done based on teams. Those teams would be functioning, particularly in terms of problem solving and you know, getting the bugs out of things using a structured problem solving method. As I said earlier, there are many of those, but DMAIC is one of them. And you know, I can talk about DMAIC in great detail, but probably this isn't the context. But absolutely, and of course, measurement. You've got to have measurement. Okay, if you don't measure your processes, you are driving blind. Okay?
The other interesting. The other comment I was going to make is how our work becomes more standard by the information systems that we have, for example, electronic medical records. Yet that is sometimes a barrier for us to adjust, to become more flexible, because that structures sometimes inefficiencies in our work. What are your comments about that?
Well, so having observed this whole situation from the patient side and having a discussion with my doctor at the time about how it had become a set of handcuffs, I will tell you that one problem with information technology-based solutions is that it's often difficult to change them. In other words, if I was advising an organization about implementing IT solutions, I would say make sure it's as flexible as possible, because you don't want it to be a handcuff.
Like Epic?
Everybody with me. And the other thing is, even if you get it right the first time, which you never ever do, so it's got to be flexible, because you know you don't get it right the first time. Okay, but things change, and so it'll be obsolete, you know, in 2 years, 5 years, or whatever, and more in the category of a bureaucracy. So, you know, that's a huge problem. Part of the art of designing processes is getting the rigor at the right level and in the right places. Okay, and it's very possible to mess that up completely. So I know you guys, I mean, I'm very aware of how I mean, Emory went through a change of the system, and it probably still is driving everybody crazy. But, you know, so if you're asking me for a silver bullet, there isn't one. Okay. If the right people had been involved early on, you know, there would have been a very serious discussion about the potential to create a set of handcuffs that are not helpful.
I just want to put one plug in for the skilled craftsperson. And this is coming from a person who actually develops processes and tries to standardize. We are responsible for being sure that sometimes a variation leads to a positive outcome, a better outcome. And we're responsible for actually catching that, because the skilled craft person is probably not going to play in the process innovation strategy that is outlaid.
Yes, so you've actually raised a very, very important idea, and that is that to run experiments to see what works or does not work, you have to introduce variation. That requires variation. You have to change something. Okay, but the difference between and you know what I'm saying is a bit of an oversimplification, but the difference between that and variation that's occurring, you know, between skilled craftsmen, particularly if you don't have good measurement in place, is that it's controlled and systematic, and hopefully designed to answer a specific question. The kind of variation that tends to happen between skilled craftsmen, particularly if there isn't a good measurement system in place, is that you really don't know what they do differently. And incidentally, one of the findings in the quality field is that in many cases, people who are superior performers don't actually understand why they are. In other words, they may tell you, why they're doing better, but it's quite frequently the case they aren't right. Okay, they probably are right more than half the time, but that's one of the learnings is that self-reported reasons for performance are frequently not right.
Can you comment on the, you mentioned you have to measure, right? We're using a lot of external benchmarking, and we're all shooting for the same percentage or percentile of the benchmark. Doesn't the industry benchmark then change, and how does that feed back into the system?
And so the answer with respect to the metrics is it absolutely does change. And so, if you're doing a planning cycle of 6 months or a year or whatever, those targets are going to change. That's absolutely right. It is important to have those benchmark metrics, but I'll point out that I did not, in the talk as I've given it up to where I stopped, did not talk about benchmarking with respect to metrics at all. I talked about benchmarking with respect to method. Okay, and metric benchmarks are important, but I personally believe that benchmarking processes and method is much more important, or at least as important, I'll say, because it is a source of innovation. Okay, and if you are doing what I've seen done in my home institution here, comparing yourself to industry average, then you're not world class. That's not the comparison you do to.
But that's the solution to keep the benchmarking relatively stable. You regress towards the mean.
Yeah. So, the key thing I want to communicate in my answer, though, is I don't want you to think about benchmarking as metrics. I want you to think about benchmarking as method at least as much.
Well, I think we're out of time. This was a pleasure, Professor Easton. Thank you for giving a wonderful talk about the intersection between implementation science and quality. And we're looking forward to additional sessions in the future. Thank you.
All right, sounds good. Thank you very much. I hope at least parts of this have been useful.
Absolutely. Thank you.